So I'm going to talk about two clinical trials, and one of which is completed and published and one of which is still ongoing. At the end I'm going to talk briefly about the potential for international collaborations that this work has been a part of and could continue into the future, particularly how we can strengthen our links with McGill. So first of all, the ACT4 trial. So I don't need to go into detail with this audience about the biology of tuberculosis, but it's well recognised that people who are close contacts of patients with active tuberculosis themselves have an increased risk of developing disease, and if they have an immunological reaction, a tuberculin skin test for example that's positive, then that confers a substantial increased risk, and therefore it's important that we offer people preventive therapy. And so for a long time there's been international policy for under 5-year-old children, and as we heard yesterday, now more recently for older people as well who are contacts of patients with TB. But the perennial question has been, how can we actually operationalise this, both in high prevalent settings and also how can we improve the way that we do this in low TB prevalent settings. Many of you will have seen this paper by Hannah Alstorf, who herself did her PhD through McGill, which shows a drop-off during the cascade of care, that in many published studies there is a substantial lost opportunity for prevention because people are not able to progress from the stage that they're identified as being at high risk through to the stage that they start and then complete treatment. Now, we know from a number of clinical trials that the regimens that we use, such as isoniazid and rifampicin and rifapentine-based preventive regimens, are effective. And so there's been a limited amount of research done looking at the left-hand side of the cascade, looking at how we can actually identify more people and get more people to progress through to the start of treatment. And so of 100% of people that are intended for treatment, only 66.7% received a test result, about a half completed medical evaluation, and only a third actually were recommended for treatment. So there's a huge gap there in practice. And so even before you start asking about whether our treatments are effective, you need to say, how can we get more people onto them? So the ACT4 study was a multi-country pragmatic cluster randomized trial. And the clusters were basic health units such as health clinics, and it was conducted in the 5 countries shown there. So Canada, so Dick Menzies was the principal investigator on this study, Vietnam, which we were involved in through the Woolcock Institute, Benin, Ghana, and Indonesia. Now, the intervention in this study was a complex health system intervention, which was adapted locally. And so there were 2 phases, and I'll go into it in more detail. The first was an evaluation of the context, looking at what the current practice was in relation to the detection and screening of people at risk of TB. And then the second phase was an intervention to implement solutions for that based upon the local context. And so there were 3 phases in this study. The first was program evaluation, where there was a combination of quantitative and qualitative assessment of the local context. That included measuring the cascade of care based upon the clinical data available. It looked at the number of index patients and contacts that were actually assessed and started on preventive therapy, and it quantified the costs within the program. Then there was a decision-making process where we engaged with the programs locally to develop by consensus what was the best combination of interventions. In general, the advice was to have a single one-stop shop for LTBI diagnosis and treatment to try and avoid people having to come back multiple times, and to use health promotion materials and engagement with patients to communicate more effectively what the benefits were to them of taking preventive therapy. And then the strengthening phase was the intervention. So looking at how to take the lessons and apply them and see whether we could use a combination of those interventions plus data from a real-life, real-time cascade of care analysis to try and strengthen the system, and to use in-service training and feedback based upon the cascade of care to improve the flow through that cascade. That is, not just to use Cascade as the diagnostic test, but actually to use it as a part of the intervention to identify the gaps and to talk to the program staff about how to address those gaps within the program. So there were 24 health facilities involved, 12 of which were allocated to each group. And you can see here that there were around 1,400 household contacts identified in the control group and about 2,700 in the intervention group. And these are the characteristics of the sites. I think one of the nice things about this study is it combines both high and low prevalence settings, and I think demonstrating that many of the guidelines that we now are developing internationally for WHO are not segregated into high and low income country settings, but are looking to try and work out what are generalizable approaches that we can take across these different settings. At the same time, I'll present to you some subgroup analyses which show the different effects in low and middle income countries later on. So within Vietnam, and I'll just talk briefly about the Vietnam component, we worked in central Vietnam in 2 provinces, Da Nang and Quang Nam, and you can see so Study 4A, which is the red ones, were essentially a pilot part of the study, and ACT 4B intervention. The yellow sites were our intervention sites, and the green sites were the control sites. And so when we did the first stage, which was program evaluation, we learned a number of things from the surveys that we'd conducted, one of which was that there was minimal knowledge about latent TB infection in the community, and that there was a lack of knowledge and a lack of prioritisation amongst healthcare workers of latent TB infection, despite the fact that it was a national policy to give preventive therapy to under 5-year-old kids at the start of the study. And we also identified that that LTBI screening had not been considered a priority compared to screening for active disease. Now, this was the baseline Cascade. So you can see here that there's a pretty dramatic drop-off between the 1,000 people who were potentially eligible and the 48 people who actually had been identified. And that relates to the fact that Vietnam had only an under 5-year-old child LTBI policy at the time. And even amongst those 48, you can see that only 6 actually ended up starting on LTBI treatment. So this proves the point that even though we have these guidelines and these effective drugs, that even before you start treatment, most of the drop-off occurs. And there's gaps in treatment, some of which we couldn't quantify because it wasn't routinely recorded. Then we looked at the strengthening interventions, and again I'm just using Vietnam as an example here. So that we decided that we would develop health educational materials regarding LTBI. We'd reorganise training about LTBI management for healthcare workers. We'd structure the intervention so we could have a one-stop shop. People would come in, they would have their screening for LTBI, and when they came back for their reading, they would either get started straight on therapy or they would be told that they don't have LTBI. So to try and minimise the number of people who had to come back more than twice. We originally thought about doing this in the community, going to people's houses to do LTBI testing and treatment, but it was clear within the health system in Vietnam that wasn't feasible, and so we had a health facility-based approach. We developed a registry which was used in every clinic that they could use to quantify their cascade of care. And then we had an excellent senior doctor perform in-service training, and he would go in regularly into the settings to educate them about how to improve progression through the cascade. This was an example of some of the materials that were developed that were cards used during the education process of patients when they were being screened for LTBI, and also educated how to produce sputum if that was required. And there was a card that they were given which contained information about what to do during their treatment. And you can see here the different countries had different approaches. In Vietnam, there was in-service training twice in the first month, where we would go to the clinic and look at their data, and then after that, every month throughout the intervention period, there would be another visit to try and strengthen the intervention. Now you can see in the red the number of household contacts identified per index patient pre-intervention, and in the green, post-intervention. And there are 2, I guess, striking points here. The first is that for most of the high prevalence, low income and middle income settings, there was a dramatic increase in the number of contacts identified per household, per index patient between the pre and post-intervention period. But the second thing which is fascinating is you can see in Canada there was really relatively little change. we can talk about why that might be, but essentially the Canadian sites are very experienced sites which have been delivering LTBI therapy for a long time, and the effect of having the registry and having the in-service training didn't substantially change the outcomes for them. And this is the combined analysis according to the Cascade of Care steps. So you can see here that across the cascade in the evaluation phase, there was a major dropout across all of the sites if you add them up together. And then you can see post the intervention with the strengthening that there was a substantial progression through the cascade. And of course, you wouldn't expect 100% of people to end up starting treatment because many people would be LTBI negative. And so this represents a very substantial proportion of those who would be eligible starting on therapy. Now, in terms of how to quantify that post-intervention, so you can see in the red box there overall that there was a 28% of contacts initiated preventive therapy in the control arm, and 35% in the intervention arm. And if you look down in the blue box, there was 14% in the low middle income country settings in the control arm who had been started on preventive therapy compared to a 52% rate in the intervention arm. So a very substantial difference between those two, as I mentioned. And so then if you look at the primary outcome, and I look here in the red box, so just within the control sites, there was a non-significant decrease in the proportion of contacts who started on therapy between the pre and post-intervention periods, whereas the blue box shows within the intervention sites there was an increase in the number of the proportion of contacts started on therapy, and the rate difference was 72 between the arms. So that is the adjusted rate of household contacts initiating therapy per 100 index patients was 72 higher in the intervention compared to the control. And that was even more pronounced in the low and middle income countries. So in conclusion, this shows that the package of interventions to strengthen screening for preventive therapy was effective, and particularly in resource-limited settings. And that having a local understanding of the factors that influence dropout is really important to try and improve progression through the cascade. And we showed the benefit of this repeated local in-service training to support staff to improve their quality of care. Now, it's not possible to differentiate between the effects of the components of the intervention because this was a package of interventions, but one of the take-home lessons from this study, which was published recently, is that this is an approach which could be used in resource-limited settings particularly to try and strengthen the way that programs can deliver LTBI therapy in alignment with international and national recommendations to do so. And although there was not a substantial benefit in the Canadian setting, I think there are still lessons for high-income countries as well as to how they might choose to improve their programs if there are weaknesses identified. So this was an example of a collaboration between McGill, the group here in the Woolcock, and many other countries, and I think emphasises the importance of multi-country studies so we can learn not just based about a single country but how these approaches can be used in many settings. Just in the remaining couple of minutes, I'm just going to talk briefly about the other trial which we have ongoing at the moment. I won't be able to present results from this trial because we won't finish follow-up until March next year, but the MDR prevention trial called VQUIN is a trial which we've been performing in partnership with the Vietnam National Tuberculosis Program, and is aiming to evaluate the effectiveness of an intervention to prevent multi-drug resistant TB. The context of this study is that preventive therapy, as we've heard over the last day or so, is important for contacts, but there is no high-quality evidence to evaluate the effectiveness of preventive therapy for multi-drug resistant TB, and there is a call within international guidelines to develop such evidence. We know that fluoroquinolones are well tolerated, and they are widely used to treat drug-resistant tuberculosis, and there's been some observational data that have shown that they appear to be associated with low rates of incident TB amongst contacts of MDR TB patients. There are actually 3 randomized trials underway at the moment looking at this question. This MDR trial in Vietnam will report first, and then there's TB-CRE, which is a study underway in South Africa, which Steve Graham is involved in, led by Annika Hessling, that will report in a couple of years' time. And then they're also using levofloxacin, not just under 5 kids now, but also now in adolescents as well. And then the ACTG Phoenix study is using delaminid as a preventive therapy. So the VQUIN trial. So this is a study being conducted in 10 provinces in Vietnam in partnership with the National Tuberculosis Program through their PMDT program. The intervention is 6 months of daily levofloxacin against a placebo and follow-up for 30 months. And the outcome is microbiologically confirmed incident tuberculosis. The context within which we're doing this are shown there. So for example, local health districts in the community or provincial tuberculosis hospitals. And you can see some of our key team here, and I just acknowledge Dr. Bing, who is the trial coordinator based in Ho Chi Minh City, visiting one of those sites. Now, I'm not able to share with you outcomes from the study, but one of the interesting data points that we do have so far is looking at the coprevalent TB. And so, in fact, prior to randomization, we detected out of the 2,048 people who are eligible for randomization, 63 cases of active TB. So there were 3,944 contacts that were screened, and 63 out of the 3,944 had active TB, so around 2%. So it emphasises that this is a pretty high-risk group for having coprevalent TB, and we're working with Marcel Baer in Canada to look at the relationship between the isolates in the index cases and the isolates in the contacts to look at the proportion that have matching drug resistance profiles and matching whole genome sequencing results. But it does demonstrate that just the act of active case finding for disease is still a very important part of this process. And in fact, that in settings like Vietnam, there may be a higher proportion because there's often delay in the patients with MDR getting diagnosed and then a delay in the contacts starting on screening. There's a number of sub-studies which are underway. So I've mentioned the molecular epidemiology sub-study, which we're performing with Marcel Baer, and we've already sent isolates over, and they're currently in the process of getting ready for testing through the Genome Centre over there. We're also working with Annalise Howard-Jones and John Idell at Westmead to do a microbiome study looking at the effect of the fluoroquinolones upon the gut microbiome. Health economic analysis, looking at the cost effectiveness of this intervention once we have the effectiveness data. Through funding through FIND and working with Warwick Britton, we're looking at the changes in biomarker profiles, both amongst active TB patients as well as amongst the contacts over time, and looking to see whether there's predictors of treatment response amongst the index cases. And looking at the pharmacokinetics of levofloxacin with Andrew Burke. And then we're planning to do a combined analysis with the TB-CRE group once our primary results have been published. All right. So just to conclude, I just want to talk about some future directions around our collaborations and what we're currently involved in. So you've heard some excellent speakers today from the McGill International TB Centre, and I really hope that over the coming years we can continue to strengthen the relationship between Australian TB researchers and the McGill Centre. There are really excellent opportunities for collaboration. We've been collaborating in relation to clinical trials that I've mentioned. Dick Menzies is one of the investigators on the VQUIN trial as well, and Marcel Baer is actively involved and an investigator on the trial. But also there are opportunities, I think, around training and around early and mid-career research capacity building. There are online and in-person training opportunities at McGill, and I think we would welcome Canadians to come to Australia as well to participate in our program. So I think we can look forward to how we can develop that relationship over the coming years. Through that partnership, the University of Sydney is now also a part of the Tuberculosis Trials Consortium. So we were a successful recipient of a 10-year grant through the CDC United States TB Trials Consortium to participate in clinical trials relating to latent TB therapy as well as active TB therapy. We submitted our application as a part of a network between Canada, Australia and Benin and Vietnam, so the so-called CAB-V consortium. And so we're looking forward to continue to work with McGill over the next 10 years, both in Australia and in Vietnam on clinical trials. And then just to make the point that the McGill Centre is a WHO collaborating centre, Ben Murray and I are leading a WHO collaborating centre for TB here in Australia as well. And so looking forward to working out ways that we can extend the impact of the research that's conducted in Australia and in the region for the benefit of people throughout the Western Pacific region. And so there are opportunities there to participate with WHO, both in evidence synthesis as well as training and capacity building. And you might like to talk to Ben further over the coffee break later about how that might occur. So I'd like to acknowledge many people. Professor Guy Marks, who sadly has not been able to join us this meeting, has been a key part of all of our research in Vietnam. Dr. Tuang, I've mentioned, who leads the Vietnam team through the Woolcock, and all of the senior staff on the Vietnam National TB program, including Professor Nguyen. So I might pause there. I think we're at morning tea time, so perhaps I can leave it for there. And if anyone wants to have a chat with me afterwards, I'm happy to answer questions then. Warwick wants to ask a question before you all get up and have your afternoon, your morning tea rather.
The intervention in ACT4, which looks very effective, is it cost effective? Because if it is, it really is a very important thing to actually implement at a program level.
Yeah, I didn't present the cost effectiveness data, I'm sorry, but yes, it is. It's actually very inexpensive to implement this package of resources. Essentially, it's like we were talking about yesterday. The development costs are, modest, $20,000 or $30,000. But once you've got the resources, the actual ongoing implementation costs are very minimal. And really, the main cost is having the person to go and do the monitoring and evaluation, and you can, embed that within the program. So I think, in terms of cost effectiveness, I think there is a strong case that this type of approach really complements the way that programs already operate. A question online, sure.
We have a question from Anne Ralph up in Darwin. Hi Greg, did VQUIN participants get routine ECGs? In Australia, we seem wedded to doing frequent ECGs for QT prolonging drugs, a real pain to implement. WHO and various other guidelines say do ECGs at 0, 2 and 4 weeks and various other time points. Dorman et al. From New England Journal of Medicine 2021, there's a citation, does 4-month TB course with rifapentine, and moxie, and they didn't do any routine ECGs. Anna is interested in what you did.
So we did do ECGs on adults, not on the kids. Although I can't quantify it, I can tell you that one of the reasons we did it was to try and address this question. And I think one of the outcomes of our study will be to show that there is no benefit to doing that. We did not detect QT prolongation amongst people using levofloxacin. We'll obviously have to wait till the final results are published, but I think having done it in this study, hopefully will avert programs needing to do it, indefinitely. Because I think for fluoroquinolones, the risk is very low. For bedaquiline, obviously, there's a different question.
Jan Willem Alphen, University of Sydney. The QT prolongation of drugs like moxifloxacin is exposure dependent. So if you're talking about high dose moxi, QT testing may be relevant for some patients with risk factors. But if you're talking about levo standard dose, I wouldn't be worried.
Thank you. Thanks, Jan Willem. All right. Any final questions before we finish up? Okay, thanks everybody. And thank you again to Faz and to Jean-Yves for your excellent presentations.